Say it over.
Yes, please.
Okay.
You're good. You're videoing.
All
Or
right.
I'm videoing you.
Hi, I'm Greg. So today we're going to go over insertion of the balloon, intra-aortic balloon. Often the balloon's been put in pre-surgery to rescue the patient because balloons inflate during diastole, increasing coronary perfusion, raising mean arterial pressure. They also deflate prior to systole, causing a lowered pressure in the aorta, lowering cardiac workload, and ultimately increasing cardiac output. So they're getting all those benefits, and you're getting them to surgery, and now they can get their heart hopefully fixed. Otherwise, you're putting the balloon in intra-op because they're worried they're not going to come off the heart-lung machine easily. And that added cardiac output that balloons help the patient achieve may be just what they need to help them get off pump. So perfusionists don't mind having a balloon in, and that's why they need to know the balloon pump well, because it helps them getting their job done and getting them off pump. So you always pick the balloon according to their height, not their weight. You know, as we get taller, our aortas tend to get longer. Thus, we have different size balloons. The balloon you use is called Sensation Plus. It comes in two sizes, a 40 and a 50 cc size. The 40 covers patients 5 foot to 5'4" in height. The 50, 5'4" and taller. And basically what's changing is the length of this part to fit their aortas. Okay. All right. Now, in the balloon kit will come two trays. Your insertion tray and the balloon tray. Okay. Also, stat lock dressings to secure the catheter with. All right. Now,
we sew it down here.
you still suture?
We suture it.
You suture? Okay.
We put a dressing at the site.
Now, in the kit will be a 30 cc syringe with a one-way valve already preloaded. Okay, so mine's being well used here. Somebody tried to put a stylet in this one. Or was it in here?
I tried.
Okay.
Because it comes out.
Right.
It's part of the...
They're not packaged with stylets anymore.
Oh, I'm
actually.
sorry.
So you don't have that. All right, now, prepping the balloon. So I'm going to take that 30 cc syringe with my one-way valve, put it on the male end of the catheter, and pull a negative 30 cc's of air and let go. We don't need to champagne cork it and all that like we used to do. The air literally will escape out the sides of the one-way valve. It won't go back in. I then remove my syringe, leaving my valve with my tight vacuum on the balloon. I then take the balloon out of the tray, set it on the sterile field. All right, it's prepped now and ready to be used if the doc wants to get it in.
Just save the syringe just in case till the balloon's inserted.
All right, we'll do that. All right, your insertion part. Now, in the kit will be a nice carrier tray with different things you may need. So you got your sheath, your introducer, your tissue dilator, and if you need to gain access, an 18-gauge needle if need be. So they'll get the needle in and get the wire in. The guide wire is an 025 by 145 centimeter guide wire, PTFE coated, all that fancy stuff. It's an 025. The lumen down the middle of the balloon is 027. So if they already have a wire in or whatever, they could put everything in over an 035, but they'd have to put this in to get the balloon in, the 025, okay? Because again, this is 027. So we get the wire in, remove our needle, and then a lot of times in the OR here, I heard it here, it's not uncommon, they may go sheathless, all right? Because they're just getting it in to help get off pump, and then they'll probably pull the balloon pretty soon after, okay? If they're gonna keep the balloon in for a while, it's better to go with a sheath, okay? Especially because these big obese patients we have, you know, if you don't have a sheath there, they'll tend to curl the catheter up and kink it more easily. So it's better to have a sheath, okay? So if I'm going with a sheath, I may dilate the hoe up. This will dilate it from a 5 up to an 8 French. The 50 cc balloon is 8 French. The 40 cc one is 7.5. So it would be a 4.5 up to 7.5, depending on which balloon. And then if you're gonna put the sheath in, we put the sheath and the introducer together, It's a push, turn, and lock system. And then we'll put that in over the wire and then remove our introducer off the wire.
That's the
Now I
sheath.
have sheath in with guide wire hanging out. Okay?
And
Or I just have the wire in.
And the size of that sheath is
8 French.
8 French.
Yeah. For the 50.
Right.
If it were the 40cc balloon, it'd be 7.5.
Okay.
Now, putting the balloon in. This is really where the expertise of the doc really comes into play, or whoever's putting it in. Because what we ask is we don't want this getting wet. So sometimes people like to pre-flush things. If they flush it via this lumen, it's going to get the balloon all wet. And then it may want to unfurl early, and now I won't get it in very easily. So it's better if I do pre-flush, hold it up and let it drip out the end. Or don't flush it at all, which is what we did.
We don't
Just
flush
don't, because you're going to draw blood back first anyway. So this is what we ask. This is what's important. When the doc's ready to put it in, that's when we ask that they pull it out of the blue T-handle, nice, smooth, and straight. So I didn't pull it out early because I don't want this getting wet. I don't want blood or baited on. Yeah. And so when I'm ready, by the way, there's a lubricant on this, so no wiping or dipping. Okay, leave it alone, doc. They're going to hold it at the tip and the base with their balloon.
Us nurses are the ones that feed it onto the end of the wire first, and then we slide it down to
backload
them.
You're backloading it?
No. So the wire's coming out of the groin, and then we feed the
Okay,
the
you
wire's
get it
so
on.
long,
All
so it's
right.
on our table.
So when you're touching it, you want to hold it at the tip and the base with your
Okay.
gloves. Grab it at the tip, thread it on the wire, then little half-inch strokes,
and
insert
he'll
it.
take it from there.
Then that's when they touch the membrane and insert it.
Because if they abrade that,
It may want to unfurl.
it may unfurl, or it may.
And now it's
quickly
hard to
tear.
get it through the sheath.
Yeah.
Now, if you go sheathless, that helps, but there's more tension going into that vessel unless you dilated it really good. But yeah, once it's high enough over the guide wire, it starts sticking out here. So, hey, doc, I got wire. Maybe we hold traction as we get it where we want it to be. If TEE isn't readily available, when you're doing these kind of insertions, we always have it. Measure at the angle of Louis to the umbilicus and then over to the groin, and that's the approximate insertion length. So then I'd measure that out and go, all right, 3 marks from the end here. All right, that's how far we'll put it in. All right. Once we have it where we want it to be, and really technically where we want the tip to be is at the 2nd to 3rd intercostal space. So just distal to the left subclavian, about 1 to 2 centimeters. Another landmark's the carina, the head of the heart. Those are good landmarks too. So we want the tip to be there, and if we size it appropriately, the base of the balloon will be above the renal arteries. All right, now we pull the wire out once we're happy with placement. Now the tube down the middle becomes an arterial line. So we're going to now hook up pressure tubing
Awesome.
in the
We
kit.
go straight to the stopcock.
What? Pardon?
We go straight to the stopcock.
Okay, so yeah, so there's different ways to do this. You can pre-flush. These are 2 4-foot pressure tubings that come in the kit. So I either use these with my 3-way and set up my art line, and maybe I flush them and hand it off the field to connect to the transducer, hang it on the pump, or or I don't use these and I'd have them dump on my field a transducer kit, and I use that tubing and set it up. I don't add more than 8 feet though. 8 feet come in our transducer kits because that prophylactic 3 cc per hour flush that transducers innately do works optimally if it's 8 feet or less. So don't go past 8 feet, okay? And then the 3-way somewhere here. And then what am I gonna do? I'm gonna draw blood back a good 10 cc's. So I'll hook up to my 3-way, draw a good 10 cc's back, discard it. Then I'm gonna draw up my hep saline, whatever I have on the field, and I'm gonna flush back a good 10 cc's to the patient and turn the 3-way off to the patient. Now I can, if that doc's still happy with placement, we can work on securing it. So we either suture it to the leg or the stat locks, and then I'm gonna start working on getting the pump going. We get the pump on in the room, We're going to undo the one-way valve, hook up our gas line tubing, male, female go together, and then note the fiber optic sensor. We're going to leave this cap on it. Don't remove it early. Blood, betadine could get on it. The person connecting to the pump should be the one removing this cap. So I'm going to hand off my sterile field, the fiber optic sensor along with the male end, and then connect those to the pump, press start, it'll autofill, calibrate, start the therapy. It'll take 46 seconds. It pumps a little bit while it does the calibration, and then it'll get the therapy going. And now
So
we'll
that's when the
work
surgeon
on,
asks if it's working.
right.
Install.
And then I'm working on getting my full setup of the art line. All right? So initially I didn't have to have the art line set up perfectly.
We do. They pass.
go ahead and do it?
They pass it right
But
off.
and that's
All-
fine.
all
But
three
I'm
go
saying
off together.
technically you can get the therapy
forget it.
going
Yeah,
before you set up the art
Yeah.
line.
Yeah.
If you had to.
yeah,
That's when then I'm going to not have the off to the patient anymore.
The surgeon does it.
Right.
yeah. We pass.
And then yeah.
They pass it.
And that's the part where there's different ways of
Yeah.
doing it. It's just as long as we get it done.
Another important thing for you guys, because these guys are newer to this,
Right.
is that when you're passing off the fiber optic, try
Mhm.
not to make any knots in it.
Yeah.
Or
Just
You
leave
know,
it the way it is.
and
It
just hand
is-
it off, because you know what? Sometimes you're used to not you. I've seen people like if they're handing something off, right? They'll take it and they'll try to straighten it out,
No.
and they'll pull it tight, and then you've got a knot in it,
Or whatever.
and
Yeah.
then you've broken the fiber.
Because
optic
yeah, it's all
cable.
like this. They undo
We've
it and
had
they're in a
that.
hurry.
It's
and
not that
You
bad.
undo it, and then you just
It's
you know
much
how like
nicer.
you grab something like
This
such a
is
line,
Kevlar
right, and you'll sort of,
coated.
like, go like this to get the knot out.
So it's bulletproof. So if somebody's shooting at you,
Have they changed
Yeah.
it?
no, it's the same.
Okay.
It's Kevlar coated because otherwise it'd be too hot to the touch.
Mm.
Because it's sending that signal,
Fast.
that light signal down the line.
Okay.
And just so that's it, really.
Is that it for insertion? I'm going to stop
for
it.
insertion.
Okay, thank you.